Maybe a little bit over.
Okay, I think we will get started. Good morning, everybody. Good morning welcome to the first multimodality imaging conference for the Mount Sinai Health System. We have a great case that will be presented by our advanced cardiac imaging fellow, Dr. Solomon. And also we have a great panel. We have Dr. Vikram Angurgal, who is the director of the cardiac imaging from Morningside. And I want to thank him for coming in person. We have Professor Zaidi, the section head for adult congenital heart disease program. We have with us for the first time an outside of cardiology, friend radiologist, Dr. Nadine Sauder, director of pediatric and congenital MR at the Mount Sinai Hospital. And also we have Professor Dankas, director of Mount Sinai Queen's Cardiology and also the president of SKY. And we have with us to moderate the discussion, Dr. Hadley and also myself. And also I would like to point out that we have fellow applicants that are being watching, so we have to make it a great conference. Again, good morning and thank you. And thank you, Dr. Pat, for attending this conference. Solomon, take it away.
Thank you. All right, good morning, everyone. Again, a special welcome to all the fellow applicants on the line. Again, I'm Solomon Beanstalk. I'm the Advanced Cardiovascular Imaging Fellow here at the Mount Sinai Hospital. If everyone could just take a second, log into polev.com/SolomonBeanstalk321. There's going to be some interactive audience response questions throughout that will hopefully be good jumping off points for the panel. So let's get started. So starting off with the case presentation and the one-liner. So we have a 73-year-old male, a history of hypertension, hyperlipidemia, sleep apnea, and obesity, who presents for cardiovascular evaluation on February 23rd of this year as he was experiencing mild fatigue and dyspnea on exertion. So a little bit more about the patient's history.
Are you sharing content?
Yeah, I'm sharing over here, but they want it over there too.
That's
fine.
No problem. Keep going.
Yeah, we can see it on film.
I did it. Okay, good. All right, great. A little bit more about the patient's history. So review of systems during that office visit was negative. No chest pain, palpitations, dizziness, syncope, orthopnea, or P&D. In terms of social history, the patient is self-employed, rare cigar use, drinks 2 glasses of wine daily, no recreational drug use, and he's married with 2 children. Family history was completely non-contributory. No known drug allergies. And in terms of home meds, the patient was on Ramipril, Crestor, Zetia, and aspirin. So this was the initial physical exam during that office visit with Dr. Dangas. And these were the labs obtained during that office visit as well. So patient was afebrile, heart rate was 71, BP 142 over 75, sitting 98% on room air. BMI was noted to be 30. And the physical exam was really unremarkable, aside from some trace peripheral edema. And the labs obtained were a BMP that was notable for a potassium of 4.5, creatinine 1.13, and a BNP that was normal at 31. This was the patient's initial EKG, which shows normal sinus rhythm, first-degree AV block, otherwise pretty unremarkable. Dr. Stern, sorry, it was scanned in, so the QRSs are a little faint, but that was the...
Something to keep in mind as you then show us the imaging stuff. He's a hypertensive gentleman, but he doesn't have much voltage. So either it's because he's fat or because something else is going on. Or because we're just insensitive to pick it up.
All right, sounds good. So he was sent for a 7-day cardiac monitor as well. And again, pretty unremarkable aside from that first-degree AV block. Very small burden of PVCs, very small burden of PACs, had 8 occurrences of SVT, longest episode was 11 beats, otherwise nothing much going on here. So this was the initial echo that was ordered during that office visit. We have a bunch of imaging experts here. Dr. Agrawal is joining us. Dr. Agrawal, if you can just look at these images and give us your assessment. We have more images coming on the next slide as well.
Sure.
So just looking at these images, you have your parasternal long axis, four chamber and your short axis views. The thing that stands out on this the most is the right side of the heart seems pretty dilated. The right ventricle is dilated, the right atrium is dilated. It seems to be compressing on the interventricular septum and compressing it. So the left ventricle appears to be smaller in size. Seems to be a case where we have to be mindful of any condition associated RV volume overload. That's so far what we can get from here.
All right, great. So we have some more images here. So what do you think about these?
So over here you have your tricuspid regurgitation that is being shown in the first image with the color Doppler. There is about mild to moderate tricuspid regurgitation. The second one is your continuous wave Doppler. I think the velocity is about 2.6.
Yeah.
So the PA pressure or the RV-RA pressure gradient is about 27. Your TAP-C is preserved. So although the RV is dilated, it's not really hypokinetic for now. And similarly, your S prime is 17. Again, consistent with preserved RV function for now.
Terrific. So again, this was exactly how it was read. Some RV dilatation, but normal RV function as we saw. Interestingly, this was something I added in, but there was no bubble study performed. So that was something I was looking for, big RV. Why is the RV big in this patient? But at that time, there was no bubble study. So here we go. First audience response question. I'm gonna change the screen share here.
Are you saying again how they can connect? So in case if
Yes. So if everyone can see here, so polev.com/SolomonBeanstalk321. Let me activate this. All right, so this is the first audience response question. So we see the RV is enlarged. You just heard the case presentation. What is your differential diagnosis at this point? And you could just, there should be a text box. You can put in what you think. So this is a word map. So the things that have the most responses are going to be the biggest.
Well, the initial response is always big.
That makes sense. It is biased. It is biased. Once.
Yeah, I was gonna say. As these are coming in, do you have more echo images, or can we just talk more about the echo, or
You can.
can we open it up, or?
Absolutely, absolutely, please.
So,
It should be on.
It's-
Hello, yeah.
so
Just a couple of things.
from an echo standpoint, and you see some,
Can you hear? I can hear. So when you look at something that's our right-sided enlargement, and as was mentioned, I mean, looks like it may be a volumetric phenomenon. I mean, that's certainly something. Then more for the fellows, you always have to think in your mind, if this is a volumetric phenomenon to the right side and the heart's enlarged, then where is the volume coming from? And if that volume's coming into the right side of the heart, and that's how you're thinking that this is right-sided volumetric enlargement, then you need to go looking for some sort of mechanism that is causing that volume to come into the right side of the heart. So even though there you can say right heart, right atrial, right ventricular enlargement, we really haven't thus far figured out where the volume's coming from. So in your mind, start thinking anatomically, what can give you volume, right? And that sort of leads you to the next layer of testing, even within the echo itself, as to where you would look. And I can add to that if you want, or somebody else can too, but you have to look for reasons of volumetric enlargement.
Absolutely. I mean, so just looking at this this word map. So ASD, as Dr. Dangus said, that was the first response, and that response may be a little bit biased, but that's the biggest one there. We have RV disease, anomalous pulmonary venous return. We have AVMs, pulmonary hypertension, a bunch of times pulmonary hypertension spelled different ways, ARVD. So the word congenital, which I know Dr. Zaidi likes to see up there. Up top, it's up top, exactly. So we actually have another audience response question here. And, all right, so what would you do next in this patient? So an echo with a bubble study, cardiac MRI, they keep going, all right. A cath with a shunt run, a CTP protocol to look for pulmonary embolism, or none of the above, you would do something else? It's a good system, yeah. We have a good amount of responses. Let me see the ones down here. All right, so the majority of people say to do a bubble study, but there's also people saying to do a cardiac MRI. People are saying, let's hold off on the cath with the shunt run for now. And we don't think this is a PE, and people agree with the management decisions that we have listed here. So let me go back to,
So why is it not a PE? Not that I think it is. Why would this not be a
Let me give you
PE?
some more information. This is a very interesting thing. Let me give you some additional information, is that the patient is overweight, but is not obese. And the patient had returned from a very long flight of 15 hours. About a week before, he noticed the edema, the swelling. He reports it, he hadn't noticed it at his previous destination, so perhaps it had developed recently, but he did admit that he had a very high salt diet during his vacation time. Whatever this may present a clue or not, but here we are.
The reason I was asking rhetorically, partly, was if it's a PE, the RV should look like garbage if it's dilated, and it doesn't.
Right.
It looks like good function, but dilated.
right,
A PE won't do that, so that was my point, nothing more.
And can I add one more thing? So you had, I said not none of the above, but was there anything else? So one of the things, again, not knowing at this point in time where we're at, is could you do anything else on echo outside a bubble study that can give you an indication of volumetric enlargement of the right side of the heart? And there are some techniques on echo that you can still look, even though I understand this is an adult patient, but just purely from an echocardiographer standpoint, what else can you do? Well, you can do subcostal imaging, and you can actually put the probe in the subcostal and then sort of sweep through the septum, either the atrial septum, and it's unlikely going to be VSD, obviously, or can you see veins that are on echo? Very hard in an adult patient, but you have to start thinking, even though we can go to a bubble study, but could there be any, so a technique is subcostal imaging, which sometimes we forget to use.
As a pediatric cardiologist, when we're looking at those studies and we see RV dilation, and we often do get some of Dr. Zady's patients. So when we look at that, we're thinking two things. Is it dilation from RV volume overload, or is it dilation from a cardiomyopathy? Obviously, with ARVC, you can still meet criteria by having normal function, but if you have dilation and RV wall motion abnormalities. So one thing we make sure is, one, we see the RV free wall, and it's very hard because it's very anterior. Another thing we think about too is pulmonary hypertension. I didn't see that much right ventricular hypertrophy. So, if we do have some elevated right ventricular pressures from an increased pulmonary flow, that might happen, but we don't see that much right ventricular hypertrophy. The other thing we look at is if there is volume overload, where is that volume overload? So we're looking at the atrial septum, we're looking at the pulmonary veins, and we're looking at the coronary sinus as well. And if I'm thinking from an adult standpoint and the views that are available, I'm looking at that 4-chamber. So do I see, I looked at the AV junction. Is that AV junction intact or not? Is that a primum ASD? I didn't see one. From that 4-chamber, if you sweep a bit posteriorly, you will see the coronary sinus. And if you don't see the coronary sinus, and you see something that looks like an ASD in the bottom, part of the atrial septum, then you're thinking to yourself, is it a coronary sinus septal defect? And that can cause right atrial and right ventricular dilation, and it's easily missed. And the other thing is looking at the atrial septum from subcostal is one way. Adults, it's tough because they don't have great subcostal windows. So we do right pedasternal views. We turn the patient to the right, and instead of looking at what we would do for a left pedasternal view, we would do a right pedasternal view. And you can see the IVC and the SVC coming into the right atrium, and if there's any atrial septal defect, the septum is right there, so you can see that. And then finally, we definitely look at the pulmonary veins, which are quite tough to look at in adults, but we do that from a pedasternal short, and I have to say, that we're very happy in an adult to see the lower ones. So if we see the lower ones, we're like, okay, at least the lower pulmonary veins return normally, but we still have RA and RV dilation that we cannot explain, and the upper pulmonary veins are tough in adults. If we see them, great. If we don't, very high index of suspicion that they're going somewhere they should not be going.
All right, great.
Maybe just because we discussed a bit about PE, it's unlikely to be an acute PE, but based on history, how about resolving moderate PE that occurred in a time frame of 2 weeks ago as per history, the target trial? How about that? We're very used to the differential diagnosis of PE in the ER as a phenomenon and as a diagnosis that occurred within 24 to 48 hours, perhaps. But maybe not facile into figuring out a PE that is in a subacute phase, often in a resolving phase, rather well tolerated.
Great. All right, so the patient had follow-up with you, Dr. Dangus, in August. He was still reporting mild dyspnea on exertion, some fatigue, but denied other symptoms. And this is from the note, the patient had an echo with RV dilation, maybe some dysfunction, and a cardiac MRI was ordered for cardiomyopathy/myocarditis evaluation. So let's take a look at the cardiac MRI.
It sounds like nothing in this discussion was on the differential on that note.
Right, exactly.
That's not a good sign.
So this is the cardiac MRI. It was performed on August 21st. And thankfully, we have a cardiac MRI expert here, Dr. Schwader. If you could just take us through, this is the 4, the 3, and the 2 chamber views, and we have more coming up.
So I'm looking at this MRI, and these are the standard views that we get in, if it's an adult cardiac MR study or if it's a congenital or a pediatric cardiac MR study. And similar to the echo, the first thing that catches your eye is the right atrial, right ventricular dilation. The other thing is, I'm looking at this, the RV function looks normal. I'm looking at the RV free wall. I don't see any dyskinesia, any regional wall motion abnormality. And then when I'm looking at that 4-chamber, I can already see the descending aorta, and on the opposite side, that would be the right lower pulmonary vein that returns and connects normally to the left atrium. I can also see the part of the atrial septum on that 4-chamber that's what we would call, that's where a secundum ASD would be commonly present. Now, we're not looking at the entire septum. We're looking literally at the area of the septum that's behind the aortic root. And I don't see any large defects. Now, one of the things you might see in our report, small defects cannot be completely excluded. That's because if a defect is 3 millimeters and the slice is 8 millimeters, we're gonna miss that defect. But we also would think that if there is a defect that's causing atrial and ventricular enlargement, so volume overload, that we would see it. And then looking at the tricuspid and mitral valve, interestingly enough, the echo reported mild TR, mild MR. Usually on on the MRI, we would not say qualitatively mild or qualitatively moderate unless we can calculate a degree of regurgitation. We would say there's a systolic dephasing jet of TR or MR because we can't use the width of the jet or the characteristics of the jet on MRI to describe or to quantify the degree of regurgitation. We can see that there's no left ventricular outflow tract obstruction. The aortic valve leaflets are, at least on this MRI, thin, similar to the mitral valve, and that the LV function, to me, it looks a bit hyperdynamic on the upper end of normal. Other than that, I don't see any right ventricular hypertrophy or any significant left ventricular hypertrophy.
That's a great point that you say that you have to, because you have to know what you are looking for. As you say, for the atrial septum.
Oh, sorry.
No, it's okay. For the atrial septum, if the cuts of the atrial septum are not thin enough, you can miss ASD. So that's why it's very important, because sometimes you can do an MRI to look for ASD and you say there's no ASD, but really you don't go through the septum from top to bottom and thin slices to be able to detect it. So that's actually a very important point. That's why we have to know what we're looking for. Otherwise, you can miss it even with MRI.
So, sorry, just a quick point, just to echo what has been said over here. One of the things that, at least when I was a general cardiology fellow, which I did not realize, is cardiac MRI can miss a lot of things if you're not looking for it. This is something that should be mentioned. What it means for the general person out there is that be very specific with the questions that you're asking. The questions that you ask determine the protocol that we do. Otherwise, the patient can be under the scanner for 3-4 hours and we still would have answered all the questions. That's one. The second thing is that cardiac MRI is not a very sensitive technique to pick up very, very small sort of intracardiac shunts. Remember, as was said, these slices are 8 millimeter slices, and you're looking at things which are about 2 or 3 millimeters quite often. That is why, unless you have a very, very high suspicion and we are going out there looking for those cuts specifically, we can miss very small things. So for the average person out there who's probably not going to pursue a career in advanced imaging, the more specific your question will be on cardiac MRI, the better answers you will get. The more vague and more general your questions will be, we are likely to miss things. So keep that in mind.
Just for the sake of time, I'm not going to belabor this, but just 2 points real quick. I think Nadine highlighted this. Always look for other things. I know we're focusing on the right side, but the left side is normal here. So that's important. That was on echo, it's on MRI, but the left side's okay. And the other thing is, again, it's always the sequences that you choose and the protocol that you choose, because you might miss stuff as everything. So we're spoiled here because we text each other all day long as to what sequences we need, but it may not happen in a community setting.
Absolutely. All right, thank you very much. So this is just a short axis stack from base to apex. Only 4 views here. Anything to add?
The one thing I would add, and is pretty significant here, is that there is diastolic septal flattening. When you look at the septum, it kind of flattens in diastole, you see a D shape. Other than that, everything we've seen, we also see part of the atrial septum on that first top view on the left, which is at the base. Part of the atrial septum, you see it, but not really, like, as was mentioned, if I get a patient with RV volume dilation, and the question is, why is the RV dilated? I would prescribe a cine sequence that is what we would call a bicable or a sagittal of the atrial septum. That would be 5 to 6 millimeters, and that would span the SV from the right upper pulmonary veins, so from the right-sided pulmonary veins, all the way to the aortic root. And that would allow me to kind of exclude most interatrial shunts, except for probably an AV canal or a primum atrial septal defect, which is best seen from a 4-chamber.
Great. Moving along. So on the left here, we have the black blood. And then here, we did a special sequence. It's kind of like an MR pulmonary vein protocol. So I'll play first the cine of the black blood, and then we can look at the other protocol as well. Hold on. Here we go.
Well, you want to orient the people, because
Yeah, so these are both axial views, and we're starting kind of at the top of the chest, and we're kind of moving our way down in thin, or maybe not too thin, but in thin slices.
What's the thickness of the thinness of the slices?
I think the black blood is pretty thick. I'm not exactly sure. Maybe
It's 8 to 10.
8 to 10.
you want to show the vessels?
Yeah, so absolutely. So this is the aorta, this is the SVC. And as we're coming down, we can see here that there looks like there's something joining the SVC. And again, right here, something joining the SVC. It looks like these are the pulmonary veins kind of anomalously draining into the SVC. This is seen a lot better on this view here. And again, these are the arch vessels, the aortic arch. This is the SVC coming down right here where my pointer is. And you can see right there and right there, there are pulmonary veins draining anomalously into the SVC. Dr. Schwader, anything to add here?
Yeah, so if you, I agree, the black bloods are thick, so sometimes it's tough to see, and also the veins are black and the arteries are black, so it's also tough to see if what we're looking at, is it a branch of the, is it a right pulmonary artery branch or a vein, so you have to play that a few times. I would say when we are looking in general, be it a black blood or even our survey when we first started, or the angiography sequence that's being shown there, we are looking at it systematically, right? I mean, obviously, we kind of know what the diagnosis is, they gave us the case, but when we don't know what the diagnosis is, we follow this systematically. So usually we start from the bottom up, and we make sure that we have levocardia, and we start very basic. We have levocardia, we have the IVC that goes into, and if you want to go all the way down and we can walk through that, we have the IVC going into the right atrium. We have the right ventricle. Are we convinced, be it from this view or other views, that this is a right ventricle? And we make sure that what comes out of the right ventricle is the pulmonary artery. And the same thing for the left ventricle. And then we look at our systemic and pulmonary veins. And unless we do that, we can miss things. So essentially here, as he's scrolling down, you kind of see the right upper joining the SVC. How do I know it's the right upper? I can see it coming from the right upper lobe, and I also can see the RPA right behind it, and I can see it join the SVC at the level of the right pulmonary artery below the azygos. And then right there where the pointer is, if you come up, you see that there is a deficiency in the posterior aspect of the, like right at the SVC RA junction, so a little bit above. It gives you a hint that we could be, yes, right
It's good
there.
if you can freeze it and you can please point with a pointer, so
Right
I
there.
think,
So one more
otherwise I
down.
think that
One, two.
attendees.
Yes, right there.
Right there.
Yeah, right there. So you see
Please
that
show
pointer right
exactly.
there. So
Please show the pointer.
So right there, there should be a wall, there should be a black line there, there's not, okay? So that increases the suspicion that there is what we call a superior sinus venosus defect, which is a deficiency between, in this case, the right middle pulmonary vein and the superior vena cava. That's why it looks like the defect is in the back wall of the SVC, okay? And it's not where you typically see your atrial septal defects. And some people would argue that this is not an ASD. It's an interatrial communication, it's a sinus venosus defect. And others would say, but that's still part of the atrial septum. So, and it's important to know that because when we come to repair those defects, and it's important that the defect is closed in such a way that the SVC drains into the RA and the veins drain into the left atrium in terms of baffle. The other thing, the moment we see this, and you can see that the other pulmonary veins, so the descending aorta is right there, and right in front of it is usually the left lower pulmonary vein, comes back into the left atrium. And if we keep coming, if we scroll down, we see the right lower, and as we scroll back up, we see the left upper. And quite importantly is to make sure that, right there, so quite importantly is to make sure that you follow that SVC all the way superiorly. When you see those defects, you go back to that SVC, you follow it all the way superiorly. Make sure no additional veins are draining there, because that would affect the type of surgical repair. And then you identify to the surgeon, if you see anything, how far or close it is from the actual defect and from the azygos vein. Now, this is a good, these 3D sequences are great to see vascular structures, but for the actual defect, we probably would have obtained that same axial sweep or axial stack in a cine, 5 to 6 millimeters, and in a sagittal, 5 to 6 millimeters.
Can I add just one thing real quick? But you held that image, and this is important, again, just from a protocol standpoint, is that if you see something and you don't quite know what it is, and if this was sort of being done, if I wear my congenital hat on for a second, we sort of scan at that point, and then you also want to you put sort of cross-sectional hairs, whatever you want to call it, and you want to see how high those veins, like you can't tell so much there as you would be able to if you had a sagittal view. You want to see where it's coming and connecting, which is important.
Yeah, so absolutely, and we actually push these into a 3D workstation where we can kind of move it around with a crosshair and a rotation center. We can look at it in all different views, the coronal, sagittal, and as well as the axial that we see here. So the question is why, for a cardiomyopathy study,
But do you have what is a 3D?
we have the 3D CT later, so we'll be able to see the defect very well.
Not from the MRI. That's not possible?
No, it is possible, we do that, but it shows a lot better with the CT. So I wanted to save that for later. But the question is, why did we go and do this special MRA looking at the pulmonary veins and looking very closely is because, you know, again, the study was protocoled more for cardiomyopathy, myocarditis, but then when we, in real time, looked to see if there was a shunt, looking at the QPQS that we do in all different ways, and we'll talk about that in MRI, we do it in the cath lab, and things like, we can do it on echo as well. We saw that we got a significant shunt, a significant QPQS of 1.8 using phase contrast imaging. And so we saw, okay, there is a big shunt here, we need to go find it, and that's kind of what we did after the fact. And we started doing these special protocols. So I just wanted to talk a little bit about phase contrast imaging. What is this special thing that we do to look for these shunts and things like that? Well, we could also use it, and we do use it very frequently, to quantify valvular regurgitation, less so stenosis, and definitely importantly shunts that we did in this case. So what is it? So the MRI signal is used to visualize and quantify velocity, and the flow volume is typically measured by obtaining a thin cross-sectional image of the vessel of interest using phase contrast methods that are sensitized to through-plane velocity, so looking at the velocity. And again, this was that thin cut that we had, and we were able to look at the velocity. That's what we were doing there. So the vessel lumen is covered by a set of pixels, and we calculate the flow Q through pixel I by forming the product in this equation here. And to get the total flow Q through the vessel, we sum over the number of pixels that cover the vessel lumen in that image. So again, you'll see in our reports, we constantly mention phase contrast imaging when we're looking at AI and shunts and things to that matter. Dr. Schwader, anything to add here?
We would do the same thing if there's a dilated RV. We actually do phase contrast imaging on almost every single study we do. One thing I would say is be careful, for those of you who are interested in imaging or do imaging, be careful about the velocity encoding or the encoding velocity that you prescribe. So it's very similar to the Nyquist limit on echo. You want to make sure that you are not prescribing a velocity for that phase contrast image that's less than what you would expect. So usually 200 centimeters per second or 2 meters per second for the arteries, unless there's obstruction. In our cases, we go even higher. And we go to the echo, we see what was the velocity on echo, and we multiply that by 100 to make sure that we get the proper velocity, because you can underestimate flow if you don't. And in this case, you would underestimate the shunt. And also you want to make sure that you're prescribing the image quite perpendicular in two views. So we call that double oblique in two views, because if you get that vessel in an ovoid shape, not truly circular, you're not truly perpendicular to it, you will overestimate the flow. So all of these measurements that we do are really reliant on prescribing at the correct velocity and prescribing the correct plane.
Yes.
This is in contradistinction to echo, where our views are more limited. We're making an assumption that it's circular, which it is not. We also have no way to do the velocity encoding that we're talking about here.
Right.
We are making the assumption. We know what it is at the highest, And it's sort of some distribution someplace, whether there's a lot of hand waving. It's done where it goes from wide to more narrow. We're assuming it's laminar, and we're assuming all the velocities are the same across this magic non-existent circle. Those assumptions aren't being made here. This is direct measurement, just to
Right.
point out accuracy and so forth.
All right, terrific. So this was the report that was done on August 21st. We saw that there was evidence of anomalous pulmonary venous drainage, right upper, right middle, draining anomalously into the SVC, and there was evidence of significant left to right shunt with a QPQS of 1.8. And we talked about how we got that. So to Dr. Dangus's point, here is the CTA. And Dr. Zaidi, if you could take us through, we have the axial, we have the coronal that really show this defect quite nicely. And then I have some still shots of the defect so we could see it really nicely as well, but we can take them through first. This is the axial cine kind of going through.
You can just orient the.
Absolutely. So we have the, again, same thing. We have the aorta here. These are the pulmonary arteries here. We start over. We have some arch vessels up here. And then this, with the contrast coming in, is the SVC here. And then right there, we can see our first view of the anomalous venous return.
So again, not to belabor this, I think it's very similar in some ways to what the MRI image is, but these are substantially clearer. But what you want to do with a CT scan is in essence, in this case, look at where the veins are coming in. We already know at this point in time that the right upper and the right middle are anomalous. What we want to see is where are they entering into the SVC? Are they entering higher up? Are they entering at the SVC-RA junction? And where is the right lower vein coming in? And it seems like the right lower vein is actually not anomalous. It's coming straight into the left atrium. So I think the left-sided are normal. Right lower looks okay, up right there. Left-sided are okay. And really the two anomalous veins are the right up and the right middle that are coming at where the SVC-RA junction is. Now, what helps is not so much on an axial section, you define the anatomy. What you want to see it on a sagittal or an off-axis sagittal as to how high the veins are and where are they entering the SVC or the RA junction. And that is important, and you see it right there. And that is important because now you need to start thinking management. And why is that important? Is because the location of where the veins are going to come in is what's going to determine how you will approach this if you're going to take this patient down a therapeutic arm, which is either surgical or transcatheter. I'm sure we're going to get there in a second. But that's why that image is important, where you can see where the veins are entering.
And then kind of coming down a little bit more, you can see that connection between the vein and the LA. Dr. Schwader, anything to add here?
So I would just point out on your axial view, you show the defect pretty nicely. You have it frozen on the axial view right there. So that is, so where, this is the defect, and behind the defect is the right middle pulmonary vein. We always emphasize to our fellows that, you know, heuristically, these veins are connecting normally to the left atrium. They're just draining anomalously, right? Because of that deficiency in the wall. And then you kind of see, if we were to look at a sagittal view, we would see that, we would see the superior vena cava kind of straddling that area, straddling the atrial septum.
That's a nice.
So right there, you
Right,
kind of
that's a
see
very
it
nice
right
image.
there.
Right,
Yeah,
right
you see
here.
it straddling. And then you showed very nicely where the right upper pulmonary vein drains with respect to the RPA. And also, if I'm not mistaken, when you, the nice thing about the CT is because those slices are quite thin, we could see that it's the right upper lobe, but it's like the right upper anterior and posterior lobes that drain. If you go back to that axial, there's actually two veins that come together and drain into that SVC.
Yes.
And so you see, okay, so right there, so you see right there, there's like two actual veins, right? The anterior and posterior. So that's kind of nice, and it's important for be it the surgeon or the catheterizer. And one thing that's also important in CT to know is you're injecting and calling and imaging at a certain time that we have prescribed. So it is quite possible that, for example, you might not see the innominate vein, let's say, or you might not see the IVC, or you might not see the azygos vein. So So it's kind of also important to compare your CT to your MRI, where those things might have been seen on a cine or in an MRI.
Okay, great.
Question over here. Do you recommend any venous phase imaging when you're doing arterial phase imaging for the congenital cases generally as a technical aspect or not really? Like, let's say this patient did not have an MRI before at centers and the patient just had an echocardiogram and then was sent for a CT. Do you add venous phases in them usually to define the anatomy better or not really?
It depends. It depends. You know, it depends if this is gonna be a if it's a pre-interventional procedure, we might do that. Usually, the venous phases, usually like we would do it in a single ventricle palliation, not necessarily in this particular case.
Okay.
I would say, sometimes if it's like, if it's requested or the catheterizers or the surgeon is really interested in that information, we'll not do it.
Absolutely. Just again, to take us through one more time, this is the SVC coming down. You see the anomalous pulmonary venous return into that SVC. This would be the SVC continuing down to the right side. And you see right here that there is that connection to the left atrium. I just want to make sure that's completely clear for everyone and all of our viewers here and at home. All right, so we have a large superior sinus venosus atrial septal defect between the wall of the SVC and the right middle pulmonary vein. And then we also have the right upper pulmonary vein draining anomalously to the SVC above the defect, as we spoke about.
I just want to make one point.
Yeah.
So, like what Dr. Argowell said about the MRI is true about the echo. The echo sonographers are only as good as what they're requested to look for. And you put up that, bubble study wasn't done. But they're only going to do it if it's requested. If the request was, RV function, that's what they're looking for. Dyspnea on exertion is LV function. They're going to do their job. So I think that's important. Had saline been done, it would have probably visualized in the left atrium from an upper arm injection. I think it's very important. You had mentioned earlier about a coronary sinus ASD, and it's very important as you're doing these studies, is don't just get excited about the one that you see, because they can come in bunches. And if you miss the coronary sinus one, which frequently people don't look at, that will also change the operative report. So it's very important, not only the inclusion, but also the exclusion, to know that it was looked for. Not only was the interatrial septum scanned, well, not only were the veins scanned, but also the coronary sinus scanned, because that's the one which can be missed, which will change the operative approach.
Absolutely. Thank you, Dr. Goldman. So then we had a cath on September 6th with Dr. Dangus. Dr. Dangus, if you could just take us through. These were two images that I thought were very interesting that us general fellows do not see very often.
Can you explain again with all the imaging why you took the patient to the cath?
No,
What's the added value?
Now the patient is potentially,
After contemplating starting up with a long trip, starting up with a high salt diet, having started with a new echo finding compared to prior echo findings. Somehow this was presented as a first-time echo. This patient had several echoes pre-pandemic that were actually in the normal range. And coming from a trip that a lot of his family members had a lot of COVID exposure, and he was concerned, despite no symptoms, about all of that. Then went through a lot of things that possibly contemplating now heart surgery. Due to the age, this patient is not a young patient, is not a patient with a very adult patient with a heart disease that been undiagnosed for many years, all his life. He's 70, he's 63. 73. So there you go. So we need to oblige to have a complete angiographic view, right and left, recalculation of the shunt, as well as possibly evaluate the length, azygos and down, of the SVC in order to contemplate the possible transcatheter options, if any. So, clearly very well substantiated for that. This is a special image requested. You can see the azygos on top of the right of the screen at the top where the arrow is, where the little hand is.
What is that little finger? Can you put that with the azygos? Right there.
Can you freeze it?
Yeah,
Yeah, it's up there, goes to the right there. You see the first shadow is up there, right there. Exactly. And then further down, towards the left side now of the screen, you would see some defects, or imagine some defects from the area where you can see the echo actually loses the concentration. That's where the other pulmonary veins come in, which is at maybe around 5 and between 7 and 9 p.m. in the clock, right there in the RA-SVC junction. You can freeze it right there. And when it becomes a little bit further down, and to the, don't leave it exactly where it is.
okay.
A little bit further down, take your little mouse, make a little bit left down, a little bit left,
Here?
a little bit left, a little bit left, go outside. You can see from there, there is some, you can imagine there is some whiteness in between the darkness of the SVC, let's say. The SVC is not as dark as it's supposed to be up top. If you are replate now and focus in this area between 7 and 9 p.m., you can see that there's some dynamic whiteness coming in that darkness.
Unpacified blood.
Unpacified blood, and you can see, I don't know what's the blood, you can see here dark and white, that's what you see here. So that's essentially the most interesting picture. Otherwise, the patient had some single vessel coronary artery disease of the OM branch. And the shunt calculation, that was very important. What did we calculate the shunt exactly? Exactly 2.5 to 3 to 1. It's higher than the MRI, and we can maybe talk about that.
That begs the question of how you decided mixed venous, but we'll put that aside.
And so,
Yeah, I know we're running short of time. Just very important from a clinical standpoint. The shunt run's very important, but your PVR there and your PA pressure is very important. So we're going to go down a management arm, but for the fellows in the room, understand the anatomy, but then understand the physiology, what that anatomy is doing. The PVR is normal here.
Well, very interesting, how we decide the PVR,
Yeah.
very good. Thank God we have IJ access. So we are very able to come a very high SVC SAT, and we were all the way down for an IVC SAT. That's a very, very important, and took a little extra time to find the IVC location from up top. And it was very handy to have the IJ access so we could control, enable actually to do a very high if need be. But clearly also the angiogram was very helpful because clearly you can see that where we are, our sheath was way above.
yeah. And so that is something that we wanted to ask.
Yeah, what is the difference?
Was why, and you mentioned that, you hit it right on the head. Why is there such a difference between the invasive QPQS and the non-invasive QPQS that we got from MRI? 1.8 to 1 versus 3 to 1.
Right.
Well, we can review the limitations of MRI calculations.
Going in the middle of this one. I'm not going in the middle of this one.
Or you can review the limitations of the oxygen saturation machine we use in the cath lab.
Yeah,
That's right.
exactly.
So there is actually data that came from Boston Children's, maybe 10, 15 years ago now, that shows that CAF calculations and MR calculations correlate pretty well, actually. And so when they don't, usually we go back to either one of our calculations and we figure out what went wrong. And also, one of the things we look at, the nice thing about MRI is you are able to calculate QPQS even with multiple sources of pulmonary blood flow, and you have different ways of making sure that your QPQS makes sense. So if you can look at your RV-LV volume, if you don't have significant valve regurgitations, comparing those two, you can look at multiple other flows to get your QPQS. But the other thing I also wanted to point out, going back to the CT, as a congenital imager, and this being an adult, we usually ask our adult colleagues to look at those CTs for adult disease. So, because coronary artery disease is such a risk factor for anything we do for these patients, and for any way we, Dr. Zaidi would counsel them. So on this particular CT, we would have called Dr. Agarwal and asked him to look at it.
Just a quick note, anytime the RV is dilated to that degree, it's at least a 2-to-1 shot minimum.
Exactly.
And this was significantly larger, so just an eyeball picture of the
Exactly.
RV, you know that it was more than a 2-to-1 shunt.
Exactly, yeah.
And just to add, can you go back one slide? It's again for the fellows to understand that, remember, as Dr. Goldman was saying, the shunt's gonna be more than probably 1.5 to 1, we get that. This is an adult patient.
Wear your adult cardiology hat on. You need to look at left-sided hemodynamics, because if you're gonna close off that shunt
And that volume's now gonna come into the left side of the heart, you need to be careful that this 75-year-old patient will handle the volume to the left side, and your wedge pressure is extremely important to know there's no left-sided valvular heart disease, either inflow or outflow. So this is very important from a hemodynamic cath standpoint, to understand that left heart will not manifest itself from a diastolic disease standpoint.
Absolutely.
And Ali, I have a question for you. Based on these hemodynamics, do you think this is a patient that's a candidate for closure?
Yeah.
With the, regardless, like.
Let's move on to management then.
Yeah,
We're getting short on time.
we're about to
Yeah.
get into that. So next audience response question, how would you treat this patient?
And I'll say, I think Dr. Love may also be online.
Here we go. How would you treat this patient? So quickly, surgical repair, percutaneous repair, or he's a 73-year-old male who's been living with this his entire life, only has very mild symptoms from, again, what I've read, but Dr. Dangus obviously knows better by seeing the patient. Would you just do nothing? I swayed somebody. All right.
Yeah, no, indeed, the patient point of view is, I was fine, we had many tests by many doctors before, it's all about my trip, what's happening here?
Right.
Why don't I just take a little bit more diuretics or something?
That's from his point of view. He's very educated, quite frankly, and all his children post their own COVID. They had Googled all about all these diagnoses by now, and they pose the exact same question.
Absolutely. All right, so it seems like most people say percutaneous repair, which is very interesting. Let's go back to the PowerPoint.
While you pull up this is a tough case. Well, it's a tough case in the sense that the management options are up there and they're not clean cut as to which way you're gonna go. Just one thing I want to make absolutely clear.
There are guidelines for ACHD, there are guidelines for exactly this, and the guidelines will tell you that if it's a 1.5 to 1 shunt, there's right atrial, right ventricular enlargement. In the absence of pulmonary hypertension and PVR that's normal, then that becomes an indication to operate or treat. But keep in mind that data comes from young patients, not comes from 75-year-old patients who've started to live with it.
Very good point. So I just wanted to basically show what the standard of care has been for many years, which has been surgical repair of these sinus venosus defects. And essentially, if you look up here, this is a graphic representation of what they do in surgery, is they basically use a pericardial patch and exclude the anomalous veins as well as the sinus venosus ASD. So that's very interesting. So now we talked about percutaneous repair, which is kind of new and exciting. And this was the paper that everyone got excited about, the covered stent. And we have an expert on the line. Dr. Barry Love, I heard, is on the line and is an expert in this procedure. Dr. Love, can you tell us about your approach to this procedure and your approach to this procedure in this particular patient?
Sure, yeah. Well, the problem I think you pointed out is, you're calling me an expert on this, but nobody's an expert on this. I mean, only a handful of these have actually been done. Mark Miller always rails about this with in general, that, a paper gets published in JACC, that's talking about 20 patients, and all of a sudden everybody feels like it's the standard of care. So we don't have any randomized data. We don't have any comparison of this compared to surgery. But the bottom line is that the idea is that the problem is really that you're missing the wall between the SVC and the right upper pulmonary veins. That's really the sinus venosus defect. And so if you're able to put a covered stent and redirect the systemic flow exclusively to the right side, and the back wall of the covered stent is going to redirect the pulmonary veins to the left atrium, then you've fixed the problem. It doesn't work very well actually if you have anomalous veins, because those anomalous veins are going to be covered by the covered stent, and then you're going to have pulmonary vein stenosis, and that's going to be a problem. This guy in particular, I think the veins that are anomalous are really right at the ostium of the sinus venosus ASD, so I think we'll be okay. Typically, you go, people have talked about it, and we've done it as well, where you go transeptal, and you put a catheter in the anomalous vein, and then when you put the covered stent in, if you have obstruction, it's a balloon expandable stent, but if you have pulmonary vein obstruction, you can inflate a balloon, and that'll sort of push the back wall out of the covered stent and leave your veins exposed. You need a very large covered stent, and some need to be custom made, and then you get into the whole problem of FDA and this and that and the other. There is some interest in doing a clinical trial. The problem is that there's not that many patients. The market isn't that big, and so it becomes a bit complicated for companies to actually run a trial to actually do this. But at the moment, we don't really have any. We don't have any approved devices to do this. We're using off-label stents at sort of their maximum size in order to do this.
Thank you, Dr. Love.
As Dr. Love indicated, there are no studies because they're very difficult to do, if not impossible to do studies. But this is a mechanical problem. It's an architectural, if you want, problem. And if you can devise something that's going to essentially think about, in my mind, think about it as an aneurysm. You have to seal up top and below, and in the middle, they hopefully allow some flow still. So this is a mandate. And how well a device can allow that. That's all essentially it needs. If the device is there, it may move, that's bad, or it may perforate the heart, that's also bad. If those things don't happen, the device will stay there and will do a good job. From my mind, that is a very simple way to approach this. And of course, you need some safety feasibility data about the basic things, but of course the technologies, we know what's the technology that does not perforate vessels and all that from everything we know already from this field. So the most trickier part is how to seal down at the RA with to actually make it very big there because the RA is very big, and still not squeeze the ostia of the pulmonary veins. That is the most tricky part. And that's why it has to be custom-made, I think, in order to anticipate how short that funnel can be in every patient, a specific patient, in order to kind of drop down the maximum diameter soon enough above the seal zone to allow the not squeeze of the pulmonary veins also.
All right, thank you. So just to finish up, back to our patient. Patient saw our adult congenital heart disease experts on September 22nd. Reported feeling well overall without shortness of breath or limitation, though he says he has slowed down in recent years. And as Dr. Zaidi mentioned, he does meet indications for closure given the elevated QPQS, the dilated RV and RA, and the low pulmonary arterial pressures and PVR, as we mentioned. And said, we'll see about the possibility of closing this via stent in the cath lab. And then on the 26th, Dr. Love again saw the patient, reviewed all the imaging, and really wrote a very thoughtful evaluation here that we already heard. And the plan in the last line here is that the patient understands and would like to proceed in early December. So that's where we are as of now. Anyone on the panel want to add anything before we close?
Yeah, just one point. Again, everything's spot on. You did a fantastic job walking us all through this. There's two things I want to point out, which is not in guidelines and is just purely bedside adult cardiology clinical care. Two things. One is these adult patients, when they've lived with right-sided volume overload, you bring the volume over to the left side, so on and so forth. The risk for atrial arrhythmias may manifest itself down the road. This is well known. So their risk of fib may or may not present itself. When you have a stent in there, or even if you baffle it across, getting into the left side of the heart might become a little more cumbersome if you want to go down ablations and things along the line. So that is something we always explain to patients. That's number one. Number two is that this patient is very lucky in the sense that even though he has a high shunt, his tricuspid valve, his RV is not so dilated that his annulus is on the right side is intact. He doesn't have severe TR, and his liver is protected.
Right.
Mild, but it could have been severe and his liver is protected.
Right.
So overall, his end organs will be fine.
And a great presentation and the discussion. Just because it's a multimodality, I would like to tell also that this can be discovered by transopharyngeal echo. So just to be complete, because we talk about high-end modalities like MRI, CT, but transopharyngeal echo can pick up this very well, both the superior ASD as well as the anomalous pulmonary vein. Just you have to, it's for MRI and CT, you have to look for it. So from bi-cable view, you just turn a little bit more and you will see the ASD coming in as well as the pulmonary veins. Just for completeness of the conference.
Absolutely. All right. So I just want to thank our panelists and moderators, Dr. Zaidi, Dr. Agarwal, Dr. Schwader, Dr. Dangus, and of course, Dr. I know. I knew you were going to say something. But most
Dr. Love and Dr. Dangas are not in this picture for the obvious reason they're going to be thanked after the December procedure. Cannot thank them prematurely.
Exactly.
George, it's because we're not good looking enough.
Most importantly, we need to show this slide. Mount Sinai Hospital is number 4 in the world in the United States and number 1 in New York. Thank you very much.
Thank you.